So welcome back guys. So today in this video I'll be talking about the detailed study of the axial section of the CT scan PNS. Now as you must have seen my previous videos, I've spoken a lot about the coronal section, how you can read a CT scan, the basics for the residents, for the ENT surgeons, for seniors as well, and for the radiologists as well, that how exactly what is expected exactly from a radiologist, and how you can read the CT PNS before a surgery. So today in this section I'm going to talk about the axial section, how you can read an axial section. For that to understand in a simpler way, I'm going to do a real-time comparison. So as you can see on the screen right here, on the left side I have the axial section, and on the right side I've got the coronal section. So I'm going to show you the exact anatomy which we already know about on the coronal section, and at the same time we can see that same anatomy on the axial section as well. So that's going to be really easy for us to understand. So before, we always ask for a CT scan for any patient belonging to any pathology, be it AFRS, JNA, intracranial nasal mass, so whatever be the pathology. So we ask for a CT scan and an MRI scan, but for the CT scan it should always be the 1 mm thickness. A standard thickness is 1 mm. If possible you can ask for 1 mm, but even better than that, to have a detailed study for neurovascular bundle, is the 0.5 and the 0.6 mm scans. They are like really helpful for the the little details that we need to understand as a skull-based surgeon and an ENT surgeon when it's concerned about the nerves and the vessels. So I'm gonna go on the coronal section first and try to concentrate on the most anterior aspect of it. Now this is the same scan which I had used in my previous video for the sagittal PNS, because I want to have the same orientation for you guys so that it becomes easy for you to understand. So as you can see over here, this is the most anterior aspect right now of the patient. So if I keep my cursor over here, now that's the frontal bone. As you can see on the same thing on the scan, you can see that's the frontal bone, that's the anterior table, and as I can keep going behind, I can still see now I'm actually entering into the frontal sinus, and that's a lot of opacification. You can see same thing you can see on the axial section over here. So far we are in the frontal sinus, but at this stage we cannot say whether it is the right or the left, because we are not able to see the interfrontal sinus septum so far. Okay, so what else we can see over here is the nasal bone and the perpendicular plate of the ethmoid. That's the bony septum and the cartilaginous septum. That's simple so far, but as we go on posterior, things start to get complicated. So we can see the same thing over here, and that's the frontal sinus, and still we can see the nasal bone, but now we can see the frontonasal process of maxilla. So if I can keep the cursor over here on the nasal beak, that's the frontal beak actually, and that's the frontonasal process of the maxilla. So at the same time we can see on the axial section, this is the frontonasal process of the maxilla and not the nasal bone, because the nasal bone is not that long. This is extending up till here, so this has to be the frontonasal process of the maxilla, which is actually lateral and inferior to the nasal bone. So the nasal bone is in the upper aspect, and as you keep on going behind and inferiorly, you can start seeing the frontonasal process of the maxilla over here. So the same thing you can see over here, and this is the first important thing. The second most important thing is, as you keep on going behind, you will start seeing the area of the nasolacrimal duct. Now it becomes very difficult for a surgeon to locate the area of the nasolacrimal duct. Now I've shown you like a lot of times in the coronal section that how you can actually find the nasolacrimal duct, and that is by the fact that you need to just follow the frontonasal process of maxilla. So as you can see over here in the coronal section, I can actually see the nasolacrimal duct. Now that's the maxillary sinus, which you can see which is starting to appear right here. But the simple trick to find the nasolacrimal duct on the coronal section is the frontonasal process of the maxilla, which becomes more and more prominent as you keep on going behind. So initially, I'll tell you this one more time. As you can see over here, this is a nasal bone. You keep on going behind, it keeps on getting more lengthier, and that's the beginning of the frontonasal process of the maxilla. And if you can keep following that, you can actually start a depression, seeing a depression over here, which is kind of opacified with grayish matter. So that happens to be the nasolacrimal duct, and you can keep following the nasolacrimal duct posteriorly. You can actually see that opening in the inferior meatus. So that's very easy to understand. And now that's the area. So if I keep my cursor over here, exactly on the coronal nasolacrimal duct, you can see that same exact nasolacrimal duct initiation on the axial scan. So if I can actually zoom this for you guys, exactly. So yeah, now I can actually show you the exact area. Now the same thing, if I keep on following the nasolacrimal duct posteriorly, you can actually see the nasolacrimal duct going inferiorly, and here you can actually see a proper circular area, because obviously the nasolacrimal duct is a cylindrical structure. It's actually a tube, it's actually a tube, a soft tissue tube. So you can actually see that's the cylindrical area of the nasolacrimal duct over here, and that is properly seen on the axial section right here. So on this section, we can see it at the base of the nasolacrimal apparatus is actually at the base of the frontonasal process of maxilla, because you must have seen or read in the theory that the anterior part of the lacrimal fossa, which is actually made entirely of the frontonasal process of maxilla, and inferiorly, posteriorly, it is made up of the lacrimal bone. So in short, anteriorly you can actually see the entire frontonasal process of maxilla, and posteriorly this area you can actually see a thin bone. Now, it's always said that the frontonasal process of maxilla is really thick. It's a tough bone to remove while you do an endoscopic DCR surgery. You have to use a ronger or the bone punch forceps to remove the bone. But when you are in the posterior aspect of the lacrimal sac over here, you can actually see this is a very thin bone over here on the posterior aspect, and that is nothing but the lacrimal bone, which you can actually remove with ease. So this is how the anatomy of the nasolacrimal duct system, the bony apparatus, the fossa, actually the lacrimal fossa, can be studied on the axial scan. So this was the thing about the NLD. So the first thing was to always locate the frontal sinus. The second thing is to locate the nasal process of the maxilla, the frontonasal process of maxilla, for locating the nasolacrimal duct. That was the second most important thing. Now going back to the frontal sinus, as I was saying, if I can just move the cursor over here. Now we all know that on the coronal section, so far as the floor of the frontal sinus is intact, the floor being the frontal beak, the short form is FB, the frontal beak, which is really important. As far as that is present, it's called as the frontal sinus, but as soon as the frontal floor disappears, it starts the anatomy of the frontal recess. The sinus disappears and the frontal recess appears. So if I can just keep this area on the area of the frontal recess and keep on going behind and come anteriorly, you can actually see that this area is actually the area of the frontal floor. That's the frontal beak. You can actually see the beak all over the place in axial scan as well. But if I can keep on going posteriorly, I can see the frontal recess initiation. That's the frontal recess. That's the proper area of the frontal sinus drainage. So this is how you need to actually correlate that same thing on the axial scan, because it can become really difficult in certain cases on the axial scan. So this was the area of the frontal sinus and the frontal recess. Now same thing, if I can show you, I want to show you the roof of the frontal sinus. So if I can keep this over here, this becomes the roof of the frontal sinus. right there. So this is whatever you can actually see on the axial scan is actually showing the roof of the frontal sinus, and that's the floor actually, and that's the floor of the area of the frontal sinus. That's the roof of the orbit actually. So this is how you can correlate the axial and the coronal at the same time. So this is really important. Now if I can show you the same thing, this in the last previous lecture I had mentioned that this is a type of a interfrontal septal cell, a huge one, which is pushing the left actual frontal sinus on the left side. And actually see that you can actually see that this is an incomplete septation over here, and the central part being the interfrontal sinus septal cell, for which this is the left frontal sinus having an incomplete the bony wall over here. So that's the septal cell in the between, and these two are connected actually, and it eventually opens up into the left frontal recess. As you can see over here, this cell opens up into the left frontal recess, and that opening can be easily seen on the axial scan as well. Same thing over here. So this is really important. And the next thing you need to remember is the crista galli, the cribriform plate, the roof of ethmoid. It is very, very important. Now a lot of young residents, young surgeons make a mistake that they think that cribriform plate is actually a part of the frontal area. But that's not the thing. Cribriform plate is a part of the ethmoidal labyrinth. It's a part of the ethmoidal bone. So as you can see over here, if I can just zoom this for you guys, the erect structure, as you can see over here, this is called as crista galli, and this crista galli is a part of the ethmoidal bone, the ethmoidal labyrinth. So it is a structure to which the falx cerebri is attached superiorly, and the one thing you need to do to differentiate that on the axial section. Now as you can see, this is the area of the crista galli. Okay, now if I can just go from above to below, this is the area of the crista galli. Now crista galli is always behind the frontal sinus. Remember that it will never be at the level of the frontal sinus. It will be always behind the frontal sinus. So if you take a sagittal section, you can always see that same thing in the coronal section as well. So anteriorly you can see the frontal table, the anterior wall of the frontal sinus like this. Posteriorly you see the sinus coming in the picture, and then eventually keep on going behind. You can start seeing the frontal lobe of the brain actually. You can actually see the frontal sinus terminating into supraorbital cell over here, and then eventually it goes off. And then you can start seeing actually at the most posterior aspect of the frontal sinus, almost towards its posterior wall. Now this being the supraorbital cell, this is already a very posterior area, as you can compare on the axial scan. Behind the frontal sinus, the crista galli will appear like it is appearing right now. So this is the concept you always need to remember. So the moment the crista galli starts in surgery, that's the area of the cribriform as well. That's the cribriform plate, under which you will find the olfactory epithelium, anterior to which in the area of the frontal sinus you will never find the olfactory epithelium. So it is very safe to maneuver your instruments there. But once you start seeing the posterior table of the frontal sinus, your olfactory epithelium will start. Okay, so that you have to remember this basic anatomy, which you can also see on the axial scan. So as you can see, this is a crista galli area. This area almost anteriorly is all above the frontal sinus, posterior table being the limit. So this area will be all the anterior ethmoid and the posterior ethmoidal area, for which where you can see the olfactory epithelium as well, and the length of the cribriform plate. So this is what you have to remember about the crista galli for the axial scan. And if you're studying it on the coronal scan, you also have to study about the Quiros classification, which I have mentioned in my previous videos. So you can go and check it out. So this was a 3 important points so far, and now we got to move on to the very fourth most important point, that is the orbit. So if I can just keep my cursor over here on the orbit and come from the exact most anterior aspect, you can actually see a very good picture of comparison on the axial section of the orbit as well. So you can see over here, that's the globe. That's the optic nerve for you on in the center right there. That's the medial rectus, that's the lateral rectus, and you can see all throughout, that's the lamina papyracea over here, that's the medial orbital wall. So the use of the axial section is such that whenever you want to study the anatomy of the lamina papyracea in cases like the CA, the carcinoma of nose, the nasopharynx extending into the most anterior aspect, severe cases of AFRS or GNA having a bulge on the lamina papyracea where you can suspect that the lamina papyracea is eroded or damaged, you can actually go for a axial section rather than the coronal section. So here the axial section plays a huge role. And as you can see over here in this patient, the entire length of the lamina papyracea seems to be intact so far in this scan at least. So this is a medial aspect of it, the medial rectus optic nerve, the lateral rectus muscle, and you can see the periorbital fat over here. So this is a CT scan, so it's all going to be shown as the same ISO intensity. So this is the throughout lamina papyracea, and if I can just go posteriorly on the coronal section, you can see my orbit over here. I keep on going behind. I can start seeing the lamina papyracea on the coronal section as well as on the axial section. Keep on going behind. I eventually can see that the entire lamina papyracea is intact. I still keep on going behind up to the level where I can actually see the anterior ethmoidal artery over here. Now, as I have spoken in my last lecture how to find the anterior ethmoidal artery, as you can see, this is the oblique skull base which you can see in the anterior ethmoids. So the Kennedy nipple sign, which we call it normally, is the conical shape of the lamina papyracea projecting from the orbit into the ethmoidal roof, and that's the area of the anterior ethmoidal artery which you can see over here right now. So if I can keep my cursor over here exactly on the area of the anterior ethmoidal artery, you can see that this is the place where the anterior ethmoidal artery is coming from. So if I can just move this ahead of here, you can actually see a soft tissue coming over here. That is a breach in the lamina papyracea. So you always have to remember that this breach is not a breach of any disease, but it's actually the gateway for the anterior ethmoidal artery. You can actually clearly see that the bone is absent over here, and you can see a soft tissue shadow. That's the entry of the anterior ethmoidal artery. But there is a thin bone which covers the canal. That's the anterior ethmoidal artery canal, which covers the mesentery, and that you have to be very careful of. So if I can go on my list, I have also shown the video of the anterior ethmoidal artery, which was kind of decent of a patient in case of chronic sinusitis. So this was the area of the anterior ethmoidal artery. Similarly, as we all know that the anterior ethmoidal artery is just few millimeters or just anterior to the bulla ethmoidalis. Not exactly the bulla ethmoidalis, but the ground lamella, which is a part of the middle turbinate. So bulla ethmoidalis is quite anterior to that. So the middle turbinate has got three parts. I can show you that on the axial section, which is really important. If you understand the concept of the middle turbinates, three divisions, I think you have half of the work done for your Ct Pns. So if I come exactly directly the most anterior aspect, I can only see what I can see is only the inferior turbinate. So if I can just keep my cursor on the inferior turbinate over here, you can actually see that this is the anterior on the axial section. This is the anterior wall of the maxillary sinus. This becomes the anterior lateral wall. This is the lateral wall. That's the posterior wall. That's the medial wall. So for a lot of residents, their universities ask about the theory question for the walls and the boundaries of maxillary sinus. So you can have a look at this. So it has got an anterior wall, an anterior lateral wall, a lateral wall, a posterior wall, the medial wall, exactly. So when you have to go for Denkers in cases of a GNA surgery, it is the Denkers, the modified endoscopic Denkers approach we use normally. These days, in this today's generation, we use the modified endoscopic Denkers. to have a head-on approach for GNA. So what we do in that is we remove almost the entire medial wall of the maxilla, which you can see over here, and the part of this anterior and the anterior lateral wall up to the level of the the infraorbital nerve actually. So this is the patient's right side. So that's the area of the wall which you remove. Okay, so up to the level of the infraorbital artery, which should be somewhere over here. So that's the bony margins of the maxilla. So you can see that this is the inferior turbinate extending from the most anterior to posterior aspect. So if I go behind on the coronal, I still cannot see the middle turbinate because it's not still visible. If I still keep on going behind, now I can actually see the middle turbinate over here. You can actually see a faint straight line over here. So if I keep my cursor over here, that's gonna be my middle turbinate. So as you can see over here on the axial section, my middle turbinate is right here. So this is how you locate on the axial section your middle turbinate. Okay, so by the way, this CT scan is a bony window and not a soft tissue window, because in my previous lecture I've also mentioned how you can differentiate a bony from a soft tissue window. So because you can actually study a lot of details in the bone and the bone marrow structure, so this is a bony window as well. So it's a bony window. And yeah, so we located the middle turbinate so far, and once you find the middle turbinate, now the part of the middle turbinate which is always attached to the cribriform plate. Now if I just move this cursor away from here, you can actually see that this is a crista galli, and that's the cribriform plate, the medial lamella, the lateral lamella, the ethmoidal fovea over here and all that. So we can actually see that this middle turbinate is attached to here the cribriform plate. So the anterior 1/3 of the middle turbinate is always attached to the cribriform plate. Okay, always remember that. So and that it is lying in the sagittal plane. So if we keep on going behind, see, as you can see, it's clearly attached to the skull base over here, the cribriform plate. So we can assume that this always will be the anterior 1/3. If you can keep on going behind, you will observe that this middle turbinate will have a bend now. See, actually it's kind of bending towards the lateral aspect, and eventually it will have an attachment to the lamina papyracea over there, just before the visualization of the superior turbinate. So as you can see over here, this is the area where my middle turbinate is having a proper lateral bend, and it is attaching itself to the lamina papyracea, and my middle turbinate middle portion will always have the attachment to the lamina papyracea, and that is we call as ground lamella. So that's ground lamella for you guys. So as you can see over here, that is now the superior turbinate over here. Now that's the superior turbinate, that's the ground lamella, the basal lamella, which is having an attachment to the medial lamina papyracea right there. So if I can just keep my cursor over this area over there, here you can see that this is the ground lamella. So whatever I can see, or you guys can see, anterior or above this pink line over here, now you can see this is a pink navigation line on the screen. This is a pinkish navigation line. Anything above this right now is all anterior ethmoids, because the basal lamella is a structure which differentiates the anterior from the posterior ethmoids. So whatever it is anterior to this now is always gonna be the anterior ethmoids, and whatever below this you can see right now is gonna be the posterior ethmoids, and this is a sphenoid, you can see as it is right here. So this is a main distinguishing point which you have to understand, that this should be the basal line, the basal lamella, which is really important. Now many surgeons do a mistake over here because they do not know the exact point of differentiation of the basal lamella. Now many of you might confuse this to be as basal lamella, this to be as basal lamella. So you need to exactly correlate the coronal and the axial section on a digital platform, and you need to know the anatomy of the basal lamella. This will be really helpful. So this is the area of the basal lamella. Now if I keep on going behind, now if my cursor is over here, now this is a superior turbinate. As you can see over here, the superior turbinate is also attached to the the base of skull actually, okay, but it is actually posterior to the basal lamella. So it is also, so it becomes actually a part of the posterior ethmoids basically. So you can see this is a septum, and it is always along the septum, not way far away from it. But then if it is too far, then we have a grading system for that as well, which is called as the Parsons ridge. Now the Parsons ridge is something which we call it as the distance of the sphenoid attachment from the septum. It is classified as A, B, C, and D, depending upon the relation of the distance between the septum over here and the superior turbinate accordingly. So the more far it is away from the septum, it is categorized as C or D. The more near to the septum, it will be classified as A or B. So that's the simple basic phenomena of the Parsons ridge, which is really helpful for opening up the sphenoid sinus ostia. So that's the basic thing about that. So you need to know on the axial section as well what exactly and where exactly you are. So behind that will be all posterior ethmoids, huge and less in number. So that's the second part of the middle turbinate, and the third part is attached to the perpendicular plate of palatine. Now if I can slowly go behind and actually see that, you can actually see that this is a middle turbinate. If I can keep my cursor over here, this is a middle turbinate, and it is bending over here in this region. If I can just keep my cursor over here, if I can still go posteriorly, it is actually coming here, almost coming here, and getting attached to the perpendicular plate of the palatine over there. So this should be somewhere here, the perpendicular plate of the palatine, that's having an attachment for the third part, and that is how we study the three parts of the middle turbinate. Now I've done a few surgeries on my channel, and I've showed the young residents of how you can actually do a FES surgery, the basics. I have explained that in very much detail about each and every step of how you can actually do FES in simple steps. So I think I've posted 3 surgical videos of FES itself, and a lot of also a video on the orbital cell as well. So I hope you can go and check it out for that. So if I keep on going behind, I am almost into the posterior ethmoids over here. So if I can keep my cursor somewhere around here on this cell, I think I'm in the posterior ethmoidal cell. That's a huge one. As you can see, I'm right next to the orbital apex region, and whatever you can see over here is the inferior orbital fissure over here. So if I can keep my cursor over here, this is the inferior orbital fissure. Now there are a few typical points which you need to remember for your ophthalmic anatomy. So as you can see over here now, if I can just come from very anterior. Now anteriorly, this is not much important except for the fact that we need to know the anatomy of the lamina papyracea throughout the length. That's the first thing. The second thing what we need to know in the orbit is the Kennedy nipple sign, that is the conical anterior ethmoidal artery, which is right here, and then which is also the second point. Third point is the posterior ethmoidal artery, which you can see again the conical shape happening over here, which is quite evident right here. So this is the area of the posterior, the same conical appearance you can see on the posterior ethmoids, where the skull base becomes almost flat and horizontal. And so unlike in the anterior, which was kind of oblique in nature. So if I keep my cursor on the posterior ethmoid, you can actually see that this is the area of the posterior ethmoid. You can actually see something coming out in the nose, and you can see the canal, the bone over here, and this was somewhere over here, the anterior ethmoidal artery, right? So this is the anterior ethmoidal artery right here, and this is the posterior ethmoidal artery right here. So if I draw a line to measure the distance between these two, anterior ethmoidal, the posterior ethmoidal, and the optic nerve, which is somewhere over here, that should form a common rule of 6, 12, and 24. Now we all know what the rule of 6, 12, 24 is, right? So I'll make a different video of that, and I'll explain in detail about the rule of 6, 12, and 24. That's the distance of the anterior ethmoidal artery from the lacrimal crest, which is right over here. So from the lacrimal crest, if we go behind, we're gonna have the anterior ethmoidal artery, which is around 24 mm, and from anterior ethmoidal artery to posterior ethmoidal artery it is going to be 12 mm, and from posterior ethmoidal artery to optic nerve somewhere around here is going to be 6 mm. So it is 24 mm, 12 mm and 6 mm. That's the rule of 6, 12, 24, which is in reverse order. Okay, so that is quite properly I think explained on the axial scan. Now this is the proper area of the posterior ethmoidal artery. That's the third most important point for the orbit. Okay, I guess the posterior ethmoidal artery is done. Now as we approach the most posterior aspect, now to understand the anatomy of the inferior orbital fissure on the coronal and the axial, we need to follow the maxillary sinus from the anterior aspect. Now this is the maxillary sinus, right? If we keep on going posteriorly, eventually the maxillary, this is the anterior aspect. Okay, so this is the maxilla, that's the okay, so if we eventually keep on going behind and reach the posterior wall of the maxilla is going to become elliptical in shape and eventually disappear. So while it is almost on its posterior end, you can actually see an opening over here. You can just keep on following. This is the proper maxilla. If I can just move this away from there, so you can see this is a proper maxilla near towards its end. Okay, so if I keep on going posteriorly, I can actually see this is almost the beginning of the pterygoid plates right now. So just before that, this is, you can see a proper dehiscent area over here. Now that's the area of the sphenopalatine foramen actually. Now that's the sphenopalatine foramen through which you can actually see the sphenopalatine artery coming out here when you do an endoscopic ligation of that artery. That's the sphenopalatine foramen right here, and very, very close to it, exactly above, you can see the inferior orbital fissure. See how close they are. So these two are in real approximation. So if I can keep my cursor on the sphenopalatine foramen over here, and you can actually see that this entire area is the area of the pterygopalatine fossa, and this is the area from which the sphenopalatine artery is going to come outside, and that becomes the infratemporal fossa. This becomes the pterygopalatine fossa. Because if I can show you the posterior most aspect of maxilla, now remember this is the posterior most aspect of the maxilla. That's the posterior wall which you have to remove in case of Denkers, in case when you operate a surgery on GNA. So it's quite clear on this section as well that this is the proper sphenopalatine canal, and that's the pterygopalatine fossa right there. So if you have a GNA over here in the origin of the superior lip of the sphenopalatine foramen, that's going to cause the Holman-Miller sign, which is the forward bending or the forward protrusion of the posterior wall of the maxilla right there. So that's the Holman-Miller sign, which you can see. I think I've demonstrated that Holman-Miller sign in previous lectures. So that's the normal canal. So whenever a patient does not have GNA, this is the normal anatomy of the sphenopalatine canal. That's the pterygopalatine fossa over here. But if a patient has a mass or GNA over here, typically on the origin place, you can always see the widening of the sphenopalatine canal and the fossa, the pterygopalatine fossa, which is a classical sign for the GNA. Okay, so this is how you study the axial scan for the canal as well. So always remember, you locate the posterior wall of the maxilla and you can get the sphenopalatine canal, and that's the pterygoid bone over there. So that's the basic of it. And the very close approximation is the inferior orbital fissure right there. So you can see that this is the inferior orbital fissure. Now if I can bring you towards the initiation of the inferior orbital fissure, you can see that this floor is quite intact over here. After some time we keep on going posteriorly, this floor disappears and forms a fissure, and that is nothing but the inferior orbital fissure. So if I can keep my cursor over here, you can actually see that this was all the orbit area, and this is the area of the inferior orbital fissure. So the GNA will actually come from the inferior orbital fissure rather than coming from the superior one. Now, normally the juvenile nasopharyngeal angiofibroma will come into the orbit from the inferior orbital fissure. I always remember my seniors teaching me this, that the inferior orbital fissure is the one where the JNA enters from. It's not the SOF commonly, but the IOF commonly. Okay, so remember that the JNA will come from the opening over here into the inferior orbital fissure, and then into the orbit, and then in the cavernous sinus and everywhere else. So this is the inferior orbital fissure. If I keep on going posteriorly, I can see actually the pathway of the inferior orbital fissure, which is very close to the pterygopalatine fossa over here and the sphenopalatine canal over here. So that's very informative for you guys. The next most important thing I think in the orbit is the superior orbital fissure, I guess, for which we have to go real posterior. So I think this is the area of the orbital apex. That's the almost the termination of the orbit. So if I can keep my cursor over here, as you can clearly see that this is almost the end of the orbit over here, and that's the sphenoid basically, and which you can have, that's the posterior ethmoids. Okay, so that's the orbital apex. That's almost the end of the orbit. You can actually see the optic nerve coming over here in the sphenoid area and forming the orbital apex over here. So this is the this has to be the area over here of the superior orbital fissure near the orbital apex. So exactly posterior to the orbital apex is the superior orbital fissure, because the structure, the neurovascular bundles which come from the cavernous sinus. Now wait, I'll show you the cavernous sinus first over here on the CT scan. So this is the anterior clinoid process, which you can see over here. That's the anterior clinoid process, the part of the lesser wing of sphenoid bone. Then comes the middle clinoid, and then the posterior clinoid, which is a part of the sphenoid bone actually. So remember that the ACP, that's the anterior clinoid process, is a part of the lesser wing of sphenoid bone. Okay, this is very important. And here you can see that the two foramens, this is medial pterygoid, that is lateral pterygoid. So if I can show you the medial pterygoid plate on the axial scan, as shown before, this was the anterior lateral, posterior, medial wall of the maxilla. That's the cheekbone, which you can feel on your cheek, where you can see the infraorbital nerve over here. And that's the medial pterygoid, and that's the lateral pterygoid, very commonly seen. So that's the same medial pterygoid, and that's the lateral pterygoid. So axial section becomes quite easy now for you guys. This becomes the lateral jawline, the temporal bone area and all that, because okay, I'll just show you that here somewhere. If I can show you that, if I keep this on the cursor over here, this becomes the jawbone over here. That becomes the area where the mandible fixes inside. Okay, so this is how you can study over the area. So that's the medial pterygoid plate. The most important thing even than this is the two canals. That's the Vidian canal and the foramen rotundum. As you can see over here, if you can keep on going behind at the floor of the sphenoid sinus, you can actually see that this is the Vidian canal. Now I always say this, Vidian is median. Okay, so whatever two structures you see, the median one will be always Vidian and inferiorly at the floor of the sinus. And if I keep my cursor right there, we can see the exact location of the Vidian canal right there. You can actually trace back the Vidian canal posteriorly to find, which acts as a landmark for the internal carotid artery in anterior skull base surgery. Now, one of the doctors asked me a question about this on Facebook, that he had an exam for the AIMS, and he was asked a question about the anatomy landmark for ICA in anterior skull base surgery. So the answer should be, I think, the Vidian canal and the Vidian nerve. So that's, you can see the Vidian nerve, and that you have the foramen rotundum right here for the maxillary nerve. And you can actually see that this is the foramen rotundum from which the maxillary nerve comes, eventually enters into the posterior pterygopalatine fossa, and from there it comes out as the infraorbital nerve on the cheekbone, okay, through the infraorbital foramen. So that is how you can locate everything on the axial scan. This is a pterygoid wedge. The origin or the powerhouse of the JNA, I guess that's the most common cause for recurrence, is that if you do not remove the JNA from the wedge over here, it's going to recur as always. So that is, you have to keep in mind. Now, this is the anterior clinoid process. Now, I was going to show you the cavernous sinus sometime back, so Let me go and find it. Okay, so once you locate, as you can see over here, once you locate the anterior clinoid process, which is a part of the lesser wing of sphenoid, which is right here, this cup depression which you can see over here, that's the depression of the optic nerve, and the bulge over here you can see here, that's the area of the internal carotid artery. So if I can keep my cursor right here, now exactly this is the area of the optic nerve. Now my optic nerve will be, the patient's optic nerve will be right here like this, as you can see over here. If I can just show you the proper anatomy. Yep, as you can see, I can actually see the optic nerve. I hope you can also see that optic nerve right there. And as you can see over here, my cursor is exactly where the optic nerve is coming right there. So that's the area of the optic nerve, which you can see over here, medial to the anterior clinoid process. This is, see how beautiful this digital CT scan examination is. You can actually read this in real time. And that is where exactly your optic nerve ends, and this is the place where the optic chiasm is formed. So if I can keep my cursor over here, this is the area of the internal carotid artery. So as you can see over here, this is the internal carotid artery over here, which comes from the neck region like this. So the parapharyngeal part, we have the cervical part over here. Then so we always have to keep the Vidian canal in mind. So we're gonna have the carotid artery coming posterior to this pterygoid wedge eventually. So if I can just show you, we can still see the Vidian canal. That's the Vidian canal over here, and we have this carotid artery coming like this above, posterior to this structure, and then bending over here to form the temporal petrous part, and then coming up horizontally above and forming the paraclival part. So the artery will be here like this, then bending here somewhere like this in the horizontal petrous part, and then coming up in the sphenoid, which to form the paraclival part initially, and this becomes medial. The Vidian is always medial to the carotid artery there, and eventually the Vidian nerve comes anteriorly and then lateral to the ICA to form the pterygopite and fossa ganglion actually. So this is how the Vidian nerve, the Vidian canal, is always a landmark for the ICA. So I think that is much more clear right now. So now time for me to show you guys the cavernous sinus. Now we all know that the internal carotid artery is a content of the cavernous sinus over here, lateral to sphenoid. So this is the area of the optic nerve over here, and that's the carotid artery. So this is the area of the cavernous sinus. So the cavernous sinus will be here somewhere, and the anterior extension, or the anterior part of the cavernous sinus, is nothing but the superior orbital fissure, and superior orbital fissure is a part of the orbital apex along with the optic canal. So this is how the optic canal, the orbital apex, and the superior orbital fissure is formed. So I think now so far the anatomy of the axial section is much more clear for you guys. This being here the sphenoid sinus, the dominant right side, and if I can show you the left sphenoid, you can have the left sphenoid right here. Now this patient is having an onary cell on the left aspect. So if I can show you the cursor here, now that's basically an onary cell, which is nothing but a posterior ethmoidal cell compressing on the sphenoid. And on the axial scan, you can actually see that the right sphenoid is so dominant and the left sphenoid over here is so compressed. Because of the onary cell in presence, it is actually compressing the left sphenoid as well. So if I can go posteriorly in this case, I can actually see that the left optic nerve is also kind of opening up into almost this onary cell and the right sphenoid sinus. So because of the excess pneumatization of the right sphenoid, I can see on the left side the nerve is actually opening almost into the left onary actually. You can actually see that this is the left optic nerve, and this is the onary cell over here, and this is the left actual sphenoid. So I can go from the patient's right side into the left side, and I can actually operate on this patient's left optic nerve if I have to do a decompression. So this is how the anatomy should be fluent and clear. I think so far I have covered almost all the important points for your axial CT scan study. So if at all you have any doubts, you can please feel free to leave a comment in the section below, and whatever study you want to do or whatever you don't get to study in your own university, you can just let me know on my inbox and my Facebook page. You can leave me a message. I will definitely reply to you. So I will teach you those topics which you don't know how to read or you have a doubt in. I'll try my level best to clear your concepts. And I think if I have missed out on any of these topics of the axial or any points I haven't mentioned so far, feel free to message me. I will cover it up in my next lecture. So till then, take care guys. I'll see you next time.